Thank you all for staying with us all the way to the end here. I hope that you'll find this informative. So as she said, I'm Laura Sperry. I'm the nurse practitioner coordinator for our deep brain stimulation program here at UC Davis. And the topic of my presentation is Shake, Rattle, and Roll, Optimizing Care for Movement Disorders. And in particular, I'm going to be focusing in on Parkinson's disease today. So the objectives that we'll be going over will be to discuss the cardinal motor symptoms of Parkinson's disease, to provide an update on the medical and surgical management of Parkinson's disease, to discuss the non-motor symptoms and strategies for helping to improve the quality of life, as well as reviewing the 10 quality measures for Parkinson's disease that have been put forth by the American Academy of Neurology. So Parkinson's disease is the second most common neurodegenerative disorder, with over 4 million people over the world over the age of 50, with rates expected to double over the next 2 decades. It is caused by the slow progressive loss of dopamine producing cells in the substantia nigra, and the non-motor symptoms are due to the loss of these cells outside of the substantia nigra, and it involves pathways of the dopamine as well as acetylcholine. By the time clinical manifestations emerge, over 60% of these cells have already been lost. So we're now appreciating that there's this whole phase of premotor symptoms that occur months to years before the onset of motor symptoms actually occur. And so we're looking at things like constipation, sleep disorders, depression, and decreased smell. So when we talk about the motor features with Parkinson's disease, there are 4 cardinal features. Resting tremor is what we call that pill rolling tremor, where you'll see them rolling their thumb over their index finger. It often is reemergent and intermittent. They will describe a sensation of internal tremulousness. It often initially starts as asymmetrical, but it will, or unilateral, it will eventually progress to both sides, but it still will have an asymmetry about it. It will involve the extremities, the face, the trunk, but it rarely involves the head, and it will get worse with anxiety and stress. Bradykinesia is the most common symptom with Parkinson's disease, and it is that slowness of movement. So it's a major source of disability, and it's often due to that decrease in manual dexterity. Rigidity is described as that increased resistance due to that occurs with the passive range of motion of the neck and limbs. It is present with both the flexor and the extensor muscles. It's relatively symmetric. You'll often feel something that we call cogwheeling if they have underlying tremor, where you will get hesitations or ratcheting movements during that range of motion. It feels like a jerky resistance. And we also describe it as a lead pipe rigidity, where they have that sustained resistance to passive movement throughout the entire range of motion. There's no fluctuations. And then we get postural instability that typically occurs later in the stages. If you begin to see this earlier on, either before or coinciding with the onset of motor symptoms, it needs to be a red flag that we're not dealing with an idiopathic Parkinson's disease, but rather more of an atypical, which is a different lecture. With the postural instability, they have difficulty preventing a fall, and this is often worsened by their stooped posture. They will have a positive retropulsion test, which is common with people with extrapyramidal disorders. And that is when you pull on their shoulders, they require to take several backward steps in order to maintain their stability. So in addition to the cardinal motor symptoms, we look at a variety of other motor symptoms, including shuffling gait, freezing, festination, which is that quickening of gait, a decreased arm swing while walking. And what happens when they have that decreased arm swing, their stride length also decreases, and that ends up increasing their instability. They have difficulty arising from a chair. They have micrographia. Their handwriting gets smaller. They have hypomimia, or that masked faces or lack of facial expression. Camptocormia, as you can see there, the anterior flexion of the spine. They have a decreased eye blink, impaired gaze and eyelid opening, difficulty turning in bed, hypophonia, or a quieting of their voice, and that is often a major complaint of their significant other. Dysphagia, siluria, which is excessive salivation, and dystonia, which is that painful prolonged muscle contraction that causes involuntary, repetitive twisting and sustained muscle contractions. And we have a couple examples of the torticollis as well as the striatal hand and toe there. So this is a gentleman that has come into our clinic. He ultimately went on to have deep brain stimulation surgery, but they undergo a pretty extensive workup before they get to that surgical process. And so they come in and they do what we call on and off testing. So they come in off of their medications so we can appreciate what their baseline symptoms are, and then we have them come back on their medication so we can get an idea of how dopa responsive their symptoms are. And this is his pre-DBS evaluation off of medication. So as you look at his tremor, you can see that it's getting worse, so that is that re-emergent tremor. If you're looking at his face, you see he has that decreased eye blink, he has that kind of masked facies. He has a decreased amplitude, he's got some hesitations in his movement. And that's what we're calling the bradykinesia. You can also note, especially in his right lower extremity, that that tremor is getting worse. It's actually worse in his left upper and his right lower. And as he is standing, he's being asked to walk. And you'll notice as he's getting more anxious about this, his tremor is getting worse. And he's really not able to move. He's frozen in place. So he's even taking the hand of Dr. Zhang, who's one of our co-directors of our program, and leaning forward, but his feet are stuck. So that's that freezing in place that you often hear about. He's just not able to move forward. So when we're looking at treating for Parkinson's disease, our main goal is to help maintain function and quality of life while avoiding the drug-induced complications. Bradykinesia, tremor, and rigidity respond very well, whereas cognitive symptoms, autonomic dysfunction, and imbalance are poor responders of therapy. So it becomes very important for us to involve our colleagues with, or to look at our non-pharmacologic interventions as really a kind of our core basis of therapy. So you want to make sure that we're involving our colleagues with physical therapy, occupational and speech therapy very early on in the process, as well as throughout the entire disease process. Initiate referrals for urology, ENT, pulmonary, on a couple things. One, Parkinson's is very all-encompassing and it impacts so many aspects of their bodies, as well as the fact that these are still aging individuals and not everything is Parkinson's. So we've got to make sure that we don't get so tunnel vision and we miss the fact that they do have other ailments going on that need attention as well. Discuss fall precautions very early on. Encourage the use of assisted devices to help avoid falls. And this is something that people are really hesitant. We all have our own notions on what it means when we finally need that assistive device. And people will be very resistant to starting to use that. So what I usually tell them is if they find that they're more stable behind the grocery cart when they're at the grocery store, they probably have some source of instability and they would benefit from having an assisted device. Have them get rid of their throw rugs at home, install grab bars and shower chairs, and discuss cues and tricks to help them overcome freezing episodes, such as marching to a command, pretending to step over an object, walking to music. People will also use metronomes, and so that constant beat seems to help them break through those freezing episodes. As well as encourage nutritional counseling, education of both the individual as well as their caregivers, and really watch for the social isolation and encourage volunteer activities, support groups, and leisure activities. Now, exercise is really one of our core components of therapy. We know that people that have an exercise regimen have an improvement in gait, balance, flexibility, coordination, pain, and they have a decrease in falls. There's also been evidence that there is a neuroprotective benefit of exercise. So we want to make sure that we're encouraging our patients to have a daily regimen of stretching and conditioning. The conditioning can really vary. So if they're fit, they certainly can still run and ski. If they're more at a moderate disease state, they can do things such as yoga and Pilates, hiking, brisk walking, or dancing. And if they're having more balance issues, they can do seated chair exercises, they can participate in gait and balance classes, or they could walk laps in a swimming pool. You also want to encourage or refer to physical therapy so they can work closely with the therapist to help them initiate that exercise plan in a safe manner. And this LSVT Big Therapy is a certification program that physical therapists and occupational therapists then can go through. There's a website and some links that I don't have time to go through today, but I did include them in the presentation. So if you're interested, I would encourage you to look at those and get an idea of what this therapy is about. It's a very intensive physical therapy program that they will go through. It's about 16 sessions in a 4-week period. So they come at least 4 times a week and they have an extensive amount of homework to do as well. But if they actually comply, they can have significant improvement with their gait and balance. And these therapists are available all over the world. So regardless of where people are, there often are options. If you don't have an LSVT Big Therapist available, you can even just do kind of a quick and dirty lesson in the clinic, really you're just you're encouraging them to punch forward and to really swing those arms really big. So all of this is about big movements. The bigger their arm swing is, the wider their stride length gets, and they have a wider platform, so therefore they're more stable. So when we're looking at medical management of Parkinson's disease, our primary goal is to control and manage our motor symptoms. These motor symptoms are due to the diminished dopamine in the brain, so therefore most of these therapies replenish, mimic, or enhance the effect of dopamine. So we're going to discuss many of the pharmaceutical agents in a moment, but we do also use targeted botulinum toxin injection, and at the bottom you can see an example of a man with blepharospasm, and you've got a before and after picture. And we use that for the dystonia. So with L-Dopa, or Levodopa, it is a precursor to the catecholamine neurotransmitter dopamine, epinephrine, as well as norepinephrine and epinephrine. It crosses the blood-brain barrier where it's converted into dopamine. Then when that conversion of dopamine occurs in the peripheral nervous system, that's when we see many of the side effects that we associate with levodopa, such as nausea, vomiting, and orthostasis. So we will commonly combine the levodopa with a peripheral decarboxylase inhibitor, such as carbidopa or benzeroxide, to help prevent that peripheral synthesis of dopamine and reduce some of those side effects. So the side effects that we'll commonly see in addition to the nausea and vomiting are drowsiness, confusion, dizziness, hypotension, and headaches. Later on, we'll see visual hallucinations, delusions, psychosis, dyskinesias, motor fluctuations, and I'll talk a little bit more about both of those in a moment, and dystonias. So to combat those, we'll shorten the dosing interval, we'll add an inhibitor of the levodopa dopamine catabolism. The other issue that you need to consider is that the levodopa absorption depends on the same transport channels that transport amino acids. So if they have a protein-rich meal, those transport channels are going to get clogged up, and the absorption of the levodopa is going to decrease. So we'll encourage people to take their medication an hour before or 2 hours after they take their protein-rich meal, which as it gets more advanced and their regimen gets closer, that sometimes can be a little bit tricky. Now, Duodopa has been available for many years outside of the United States and was just recently approved under the name of Duopa here, and it is a gel formulation of carbidopa-levodopa that is delivered through an intraintestinal pump. It has an external controller so you can make non-invasive adjustments, and the benefit of this is that it helps maintain more constant blood levels and minimizes those levodopa motor complications. Now, when we're discussing dopamine agonists, these mimic dopamine. They readily cross the blood-brain barrier, and they're longer lasting, and they have more uniform stimulation. They can be used as both monotherapy and adjunct therapy. They're very effective in treating the bradykinesia, tremor, and gait, and they're slightly less potent than levodopa. So you do need to be cautious with the side effects, in particular with the elderly. And the issues, we'll see some sleep issues, we see psychiatric symptoms, peripheral edema, impulse control disorder, where we'll see punding, which is that repetitive, relatively purposeless activity, such as organizing, sorting, or collecting things. And we'll see compulsions, and these are due to the overstimulation of dopamine receptors in the part of the brain that is responsible for instant gratification. They can get nasal congestion, it can potentiate levodopa effects, postural hypotension, and they can get dyskinesias, but it's slightly less than the levodopa. Now, apomorphine is an injectable dopamine agonist. It's considered a rescue drug. So this is used in individuals that already have existing anti-Parkinsonian therapy, and it is used to help them break out of some of those acute freezing episodes or acute off states. It has a very short half-life. It kicks in within about 10 minutes and it wears off within about 60 to 90 minutes. It does have a side effect of significant nausea, particularly early on, so we will pair it up with the anti-nausea therapy trimethylbenzamide, at least for the first several weeks, depending on how they're doing. Okay, so just saying a little bit more on the impulse control disorder. This is something that usually will be new behaviors for individuals. So these are things that are typically a change from where they're at, and they won't always share them. So you do need to let these individuals know that this can be a side effect of the medication that usually seems to break down the walls and make them feel a little bit more comfortable about sharing some of this information. But you will also get a lot of this information from the family. So you're looking at things such as gambling, compulsive shopping, hypersexuality, hobbyism, the punding, the compulsive medication use. It can be very distressing to both the individual as well as the family, and it can be quite devastating. So people will wipe out their savings in online gambling, or people that have been in a monogamous relationship for many years will start searching out partners online. So it's something, it can creep up, but it can have significant effects, and so you want to be aware and you want to act aggressively if you have any suspicions that it's going on. So if they're on dopamine agonists, we will remove them from those dopamine agonists. And then pending the concern, you may need to limit their finances or their access to medication. Now, with the COMT inhibitors, these block the enzyme that breaks down levodopa. It is administered along with levodopa. We typically use the entacapone. The tolcapone has fallen out of favor due to that risk of fatal hepatic failure, but if you are using it, you do need to be very cautious that you're monitoring the LFTs regularly. You want to counsel the patients that it will discolor their bodily fluids. It can potentiate the levodopa effects and cause confusion, hallucinations, nausea, orthostatics, as well as diarrhea. Now with the monoamine oxidase B inhibitors, these increase the half-life of dopamine by blocking down the breakdown of dopamine at the synapse. So again, these can be both monotherapy and adjunct therapy. Both the selegiline and the rasagiline have been studied as potential neuroprotective agents. While that neuroprotective efficacy has not been proven, they're still quite effective symptomatic agents in both early and advanced disease, although their magnitude of benefit is minor. They tend to be pretty well tolerated, but they do have a couple significant side effects that we need to be cautious with, and you do need to educate the families and the individual about the potential of tyramine effects as well as serotonin syndrome. And because these are selective for the monoamine oxidase B rather than A, the severity of risk for the tyramine effect and the serotonin syndrome is limited. It will get kicked back. We combine patients that are on these with SSRIs quite frequently, but it will get kicked back to you from the insurance and the pharmacy almost every single time. So it's important to be aware of that risk. It's important to educate the families about what to watch out for, but it tends to be limited. Now, amantadine has modest anti-Parkinsonian efficacy, but recently it has been shown to be very helpful in reducing dyskinesias in people with advanced Parkinson's disease. It is an adjunct to the levodopa. You also, again, have to be cautious with the elderly as well as people with renal impairment because it is cleared unchanged. And the other thing is that it has this interesting side effect of the livedo reticularis, which you can see a picture of it up there, where you get this reddish, purplish mottled discoloration of the skin. It can be associated with a slight edema in the lower extremities, but it will discontinue when you discontinue the medications. Now, the anticholinergics have come about because the dopamine and acetylcholine are normally in a state of electrochemical balance within the basal ganglia. So as the dopamine begins to get depleted, the acetylcholine becomes overactive. And so that's where we're using the anticholinergics. They're quite helpful particularly with rest tremor, but it's not as helpful with bradykinesia. And it can be used as both monotherapy and adjunct. Again, being an anticholinergic, you want to be very cautious with the elderly and you want to be aware of the side effects. Now, we know that Parkinson's disease is a progressive disease. There's this component of premotor symptoms that we're becoming aware of. About the onset of when we start appreciating the motor symptoms, that's typically when we give the diagnosis of Parkinson's disease, and it's when we initiate therapy. And people do really well for the first several years of therapy. But the dopaminergic therapy has to be converted by the neurons to the dopamine, and these neurons are continuing to degenerate over time. So as this disease progresses, there's decreased predictability of those dopamine levels, and you begin to get things such as motor fluctations or wearing off. So their medications are working for a shorter duration of time. They will describe it as periods of I'm taking my medication and within a half an hour, 40 minutes, I'll be doing okay. My medications will work for an hour or 3 hours, and then it starts wearing off. And so they end up getting these kind of undulating episodes of where they're functional and less functional throughout the day. They will also describe dyskinesias, which are the erratic, involuntary writhing movements of the face, arms, legs, trunk. And this can often be a peak dose effect, although we do also have patients that will report dyskinesias in more of the off phase. Now, the first step to managing these motor fluctuations in Parkinson's disease is to characterize the fluctuations. You want to instruct the patients and the families on the concept of and the definitions of being on and off. So on, the medications are working well, their symptoms are well under control. Off, their medications are not working as well and their symptoms are breaking through, as well as dyskinesias. A simple diary can be very helpful in tracking out when they're taking their medications, perhaps even when they're eating or exercising, as well as when their symptoms are more bothersome. And sometimes it can help paint the picture of where their troublesome spots are during the day. So once you have a pattern of those fluctuations, then you can suggest modifications to their therapy, such as adjusting their levodopa levels, adding a different preparation of the levodopa, or adding an adjunctive agent. Now, dyskinesias are interesting. A mild dyskinesia often is not even always appreciated by the individual, but it can be quite bothersome to the people that are sitting around them. So their family members will come in and they're more bothered by the movement. But something that I found really interesting when I first started working with Parkinson's patients is I would see them when they'd be so dyskinetic and I would think, gosh, they seem so uncomfortable. And then I would see them in more of an off phase when they would be really still and you think, oh, they look so much better today. When in fact they feel quite the opposite. When they're dyskinetic and they're moving, as long as it's not a severe dyskinesia, they're limber and they're agile and they're moving and they feel much better. Whereas when they're not having this dyskinesia, so they're a little bit more locked down, they can't move readily, and that is quite bothersome to them. So it's, however, for the people that are living with them or that are around them, they see the movement and they're more uncomfortable with the movement and they feel better with when they're still. So it takes a lot of education and counseling sometimes of the families and the patients about what's going on. Now, if the dyskinesias are not bothersome to the individual, they don't always need to be addressed. But if they are becoming bothersome, you can adjust the levodopa dose or the interval, you can decrease the adjunctive medications, or you can add the amantadine. So this is a video of the same gentleman, and this is him on his medication. So you can see he's quite dyskinetic. Those are not tremors. That is that erratic, involuntary movement. Although he is more on, he's blinking more, his face is more animated. But you can see those dyskinesias are really impacting his function. He does have better movement. He's moving faster. He has slightly bigger amplitude of his finger taps, so better bradykinesia. He stands up much more readily than he did when he was off. But those dyskinesias could certainly impact balance as well. And you can see he's moving much better. Now, while Parkinson's disease is often defined by its characteristic motor symptoms, the non-motor features are increasingly being recognized as a significant part of Parkinson's disease. They're less visible symptoms, and often we describe them as kind of being below the surface, but they have a dramatic effect on the psychological well-being, the social adjustment, and the quality of life of both the patients and the caregivers. The types of non-motor symptoms that we will see are things like anosmia, that decreased sense of smell, and that is often one of the first symptoms that people will describe. The drooling or dysphagia, blepharitis, hypophonia, sleep disturbances, painful foot cramps, bursitis, frozen shoulder, cognitive dysfunction, dementia, psychosis and hallucinations, mood changes, autonomic dysfunction, pain and sensory disturbances, and seborrhea. According to several surveys, depression and other psychiatric symptoms have a greater impact on quality of life than do the motor symptoms. These cognitive changes can start early on in the disease. They're generally correlated with the disease severity, but there is considerable variability. Now, while some of these patients may have a comorbid Alzheimer's disease, dementia in Parkinson's disease is primarily due to the presence of Lewy bodies in the cerebral cortex. The dementia increases the risk of medication-induced delirium and hallucinations. It leads to reduced job performances and contributes to a loss of functional abilities and is quite stressful for the individual and the families. There are very specific cognitive deficits that we see in Parkinson's disease. We see bradyphrenia, or that slowing of cognitive processes. It takes them longer to do tasks, and tasks are more draining than they previously were. They have problems with apathy, where they have difficulty getting started, difficulty following through with tasks, They may be watching television for a long period of time and not keeping up with their hygiene. They have attention and concentration issues where they're losing their train of thought mid-conversation. They have short-term memory problems, which is not actually a problem with the storage, but rather retrieval, so cues and recognition can be quite helpful. They have visual spatial deficits, where they have difficulty with constructional or drawing tasks, difficulties with geographic orientation. They get lost while they're driving. They have difficulties with visual tracking and visual attention. And they have a variety of executive deficits with problem solving, decision making, multitasking, and planning. Problems with mental flexibility. They get easily distracted by things in their environment. They become overwhelmed with new and chaotic environments, and they get stuck on certain ideas. They have disorganization and poor planning, so they have problems keeping up with their finances, and they begin losing important documents. They have problems keeping up with their schedule, and they begin missing appointments. And they have difficulty prioritizing and sequencing tasks. They have poor judgment and problem solving. They're not weighing the consequences, and they begin making bad decisions at work and with their finances. They also have some language production issues where they have a loss of nonverbal cues, poor articulation, decreased emotion recognition, restricted facial expressions, and a loss of social pragmatics where they can't tell the difference between a joke and a lie. It becomes very important to encourage the use of direct communication and less reliance on social cues. Now, from the time of diagnosis of Parkinson's disease to dementia, it averages out approximately 10 years, but there's quite a bit of variability too. It can be as soon as within 3 to 5 years and as far out as 20 to 30 years. The main difference when we're looking at mild cognitive impairment versus a Parkinson's disease dementia is whether or not their deficits are significant enough to impact their loss of independence. About 17 to 30% of people with MCI will go on to progress dementia over 5 years. And the predictors of this conversion are older age, non-tremor predominant phenotype, and worse motor symptoms on the UPDRS, which is one of the Parkinson's disease rating scales that we use in clinic. What is also important, as I mentioned before, is to note whether or not the onset of dementia precedes or coincides with the onset of those motor symptoms. Because if you are appreciating that, then you're likely not dealing with a Parkinson's disease dementia, but rather a dementia with Lewy bodies, which is quite different. You want to educate your patients to be using compensatory strategies, such as external aids. They need to use a daily to-do list and break big jobs into little steps. They should use a calendar and alarms and reminders on their smartphones and keep a routine schedule. They need to minimize distractions and do only one thing at a time. That means no talking or listening to the radio while they're driving, and limiting conversations or other distractions while they're cooking. They should work in a quiet location, minimize stimulus overload, as well as allow extra time. So these are things that they may need to go to their employer and ask for some modifications in their work environment to help maximize their productivity. While we don't actually know what activities are best for brain health, we do know that it is important for people to learn new skills, particularly those that are moderately challenging. It is important, as we mentioned before, to remain as physically active as possible. So in addition to the physical benefits of physical exercise, if we can combine that physical activity with an activity that has a strong cognitive component, such as the adapted tango class, they can work on spatial cognition, executive function, and balance all at the same time. And encourage them to remain socially engaged. That provides the cognitive stimulation as well as emotional support that is quite necessary. There have been few well-designed studies in demented Parkinson's disease patients, but there is a suggestion that cognition can be helped with the use of the cholinesterase inhibitors. The effects are modest, and for some, it can worsen their tremor. The memantidine glutamate antagonist is currently under study in Parkinson's disease dementia. Now, about 30% of patients with Parkinson's disease will be troubled by drug-induced hallucinations, and a smaller number of these patients will go on to develop psychotic features such as paranoid delusions. The risk factors are age, severity of disease, and cognitive impairment. Patients with severe hallucinations are very difficult to care for at home and often require nursing home placement. Patients with Parkinson's disease in nursing homes typically fare poorly, and for this reason, hallucinations are considered to be an increased risk of death for patients with Parkinson's disease. It is also important to note that due to patients with dementia have an increased risk of death on the antipsychotics, which becomes challenging in the therapy as well. So prior to the advent of the atypical antipsychotics, the therapeutic options for hallucinations were limited to reduction in dopaminergic therapy, a drug holiday, or the use of low doses of typical antipsychotics. There is growing evidence that atypical antipsychotics, particularly the clozapine and the quetiapine, can be quite beneficial, although there's conflicting evidence about the use of quetiapine, although we tend to use quetiapine over the clozapine mainly because it's a little bit more convenient. We have the risk of agranulocytosis with the clozapine. Providers have to be registered in order to be able to prescribe that medication. There is also increasing evidence that other agents in this class, such as the olanzapine and the risperidone, are poorly tolerated. And there is some anecdotal evidence that cholinesterase inhibitors can be helpful in some patients that have an underlying cognitive impairment. However, you also want to remember what medications they're on. So if they are on things like the dopamine agonist, we know that those could also be exacerbating psychosis, so you may need to discontinue that therapy as well. Mood disorders are a common source of disability in patients with Parkinson's disease. And it is not solely due to the psychosocial stress and the disability, but it is rather due to the neuroanatomical degeneration that's going on. And that becomes a really important point to drill home with your families, because people are often very hesitant to start antidepressants and therapy for their depression, and they're hesitant sometimes to even fully acknowledge it. They feel like they can just buck up, they can keep marching forward, and they'll figure it out. And it's really important to help them put it all into perspective, that this is a much bigger issue than something that they potentially can handle by themselves, and to make it acceptable for them to be willing to accept therapy. The depression and anxiety are also some of those premotor symptoms that we will often see for many years, that occur many years before they actually receive the diagnosis of Parkinson's disease. And although depressed mood is very common, and 40% of patients will be treated for depression at some point during the course of their disease, many of these patients will not actually meet the criteria for a major depressive episode. So when you're evaluating their depression and their anxiety, you want to look at the pattern of onset. You want to make sure that you have optimized the dopaminergic therapy, that you've decreased their off times. So ask about the disease progression, any wearing off periods, and whether or not any of their symptoms may be contributing to their anxiety. And of course, we always want to start with our non-pharmaceutical interventions: nutrition, sleep, exercise, support groups, social interactions, stimulating leisure activities, psychotherapy, and our alternative therapies of meditation, massage, yoga, exercise, acupuncture, and biofeedback. We do use our pharmaceutical interventions in these patients. Of course, if they are on that MAO-B inhibitor, you need to be cautious with the antidepressants due to the risk of the serotonin syndrome. Now this is a little bit of a busy slide here, but the blepharitis is due to that facial bradykinesia. So they have a decreased eye blink. They end up getting an increased amount of bacteria on the surface of their dry eyes. So they get a chronic eyelid inflammation and conjunctival injection. And this can be helped with the high viscosity lubricant eye drops at bedtime. The shoulder pain that they get is typically unilateral. It's typically on the side of their worst Parkinson's symptoms. It's due to the rigidity and bradykinesia that often results in that decreased arm swing. It leads to mobility, it leads to discomfort and dysfunction. And they will have issues of bursitis, tendinitis, frozen shoulder, and rotator cuff injury. So referring to physical therapy, that LSVT big arm swinging therapy is quite helpful, and muscle relaxants if it's appropriate. About 50 to 80% of patients will have difficulty swallowing. They have an impaired pharyngeal peristalsis, restricted opening of their upper esophageal sphincter, and they have a lingual tremor. They can have increased risk of aspiration and pneumonia, and this ends up being one of the primary causes of mortality in people with Parkinson's disease. And it's often not improved with their dopaminergic therapy. So it becomes very important to make sure that you are referring to speech and swallow therapy. Now, the silarrhea or drooling is not actually due to excessive salivary production, and in fact, they typically have normal salivary production, but it is due to the difficulty in transporting that saliva back to the posterior pharynx and their decreased frequency of swallowing. It's also exacerbated by that forward flexed posture that they often have. It's socially embarrassing, but it's not actually harmful. So you can encourage them to use gum and hard candies to trigger the swallow reflex. We discourage the use of anticholinergics. The side effects are not worth any of the benefits. we do use targeted botulinum toxin injection of the parotids. Now, nausea and bloating can be due to the levodopa, and if that's the case, we will add a supplemental decarboxylase inhibitor, an extra dose of the carbidopa that they'll take along with each of the Sinemet doses. It could be also due to the gastroparesis, and in that case, you want to make sure that you've managed the constipation and you're encouraging them to have small, more frequent meals. About 89% of people with Parkinson's disease will have speech and voice disorders, yet only 3 to 4% of them will actually ever receive speech therapy. So they will have a reduced loudness, a breathlessness, a hoarseness, roughness, and tremulousness. And what we refer to is the LSVT loud therapy. So this is, again, very similar to the big therapy. These are speech therapists that have gone on for additional training that is specific to Parkinson's disease. It, again, is a very intensive training program where they come in about 4 times for a week for 4 weeks period. They do need to be very committed to doing it. But if they can comply and they follow through with the program, there is a significant improvement in their respiratory, laryngeal, articulatory function, and it will help maximize their speech intelligibility. And again, the website for the LSVT Global, in order to locate therapists, is right there. You could just go down to find a clinician and you put in your local zip code. And there's also this video that gives you a pre and post of a woman who has undergone the therapy. And I don't have time to show you that video, but I do encourage, if it's something you're interested in, to see, because it's quite remarkable and emphasizes the importance of making sure that we're getting these patients to the proper therapists. Chronic sleep deprivation leads to exacerbation of daytime motor symptoms and excessive daytime sleepiness. It can often be exacerbated by inadequate tremor control or stiffness at night and poor mobility. It is really important to make sure that we're referring these individuals onto a sleep specialist. We will order a sleep study and we'll request the EMG leads to be placed on the lower extremities so that we can get a full evaluation. We want to be able to treat that underlying sleep disorder, and then, of course, review the standards of sleep hygiene with them as well. Now, in the interest of time, I'm not going to go through everything on this slide, but it is available to you in the slide presentation. But just as a quick review, the rapid eye movement sleep behavior disorder is the parasomnia with vivid dreams and dream enactment behavior that occurs during the REM sleep. Sleep fragmentation is probably the most common nocturnal complaint. We have obstructive sleep apnea. We have restless leg syndrome, where they get the unpleasant sensations in their legs at rest and uncontrollable urge to move their legs and to help relieve that feeling. And they have periodic limb movements in sleep, where they get repetitive, jerky, involuntary leg movements during sleep. They can have excessive daytime sleepiness, where they can get sleep attacks, and this can be worsened, or they can be at increased risk if they're on moderate to high doses of dopamine agonists and levodopa. And then insomnia. Now, autonomic dysfunction is quite a wide umbrella. Due to the decreased libido, motor symptoms, and impaired expressiveness, we will see sexual dysfunction. We will refer on to urology and gynecology as appropriate. If they're having hypersexuality problems, you want to consider whether or not they're taking the dopaminergic therapy, particularly the dopamine agonists, and those may need to be reduced. Constipation, of course, hydration and fiber, daily stool softeners, and if appropriate, a daily or every other day regimen of the polyethylene glycol laxative. And with both overactive bladder and urinary retention, we will refer on to urology. With overactive bladder, we do use the anticholinergics, but you need to, again, be cautious with the potential side effects, and it's very patient dependent. You may also want to educate them to be using protective undergarments and use commodes or urinals at the bedtime so that they're preventing falls and accidents as they're rushing to the bathroom at nighttime, when nighttime tends to be their more off time. They are going the longer periods between their doses, and so if they're having to get up in the middle of the night and walk to the bathroom, that can be a dangerous time for them. And then urinary retention, you want to review the medications that you have prescribed, because it may be that we may be causing that with some of the side effects of the anticholinergics that we have them on. Now, orthostatic hypotension, as you know, is when the blood pressure decreases due to position changes. So they get dizziness, lightheadedness, headaches, blurred vision, and fainting. And you want to encourage the use of compression stockings, increase their water, salt, and caffeine intake. They should rise slowly, wait for their sensations to pass before they initiate any mobility. They need to raise the head of the bed, elevate their legs when they're sitting. You want to monitor their orthostatic vitals at every visit. You may need to decrease their dose of their dopamine agonist or their levodopa, and adjust their blood pressure medications if necessary. So again, it becomes very important to make sure that you're collaborating closely with their primary care provider or their cardiologist who may be managing that. And then particularly as you want to monitor for, you want to rule out for other etiologies, but you also want to monitor for the supine hypertension, which is a side effect of the therapies that we use to treat the orthostatic hypotension. Now, as we discussed, as the disease progresses, they become more and more resistant to their therapies, and their medication therapies are not working as efficiently as they were previously. It is at that time that we begin the discussion about surgery. Surgical approaches have been proven valuable for carefully selected Parkinson's disease patients. Only those that are levodopa responsive, typical versus atypical Parkinson's disease patients have been shown to respond to these procedures. And it is very important that they have their comorbid medical conditions well controlled, that they're not demented, and they don't have significant psychiatric comorbidities. Although the surgical tide has shifted towards deep brain stimulation, the stereotactic lesions may still be appropriate in some patients. The stereotactic pallidotomy is very effective at treating tremor and dyskinesias, but it does not help them dramatically reduce their dopaminergic therapy. The stereotactic thalamotomy helps to improve rest and postural tremor, but is not effective with bradykinesia. The DBS, we will typically target either the globus pallidus interna, or the GPI, or the subthalamic nucleus, the STN, which can be very helpful. If we can target the STN, we often will see a significant reduction in their medication, their dopaminergic therapy, which can be very helpful if they're having a lot of side effects, particularly dyskinesias along with those therapies. Now, in quick review, when we're talking about the deep brain stimulator, it consists of 3 parts. So we have the lead that gets placed into the targeted location within the brain. They can have either a unilateral or a bilateral lead implanted. It is attached to lead extenders that come down the back behind their ear and extend down the side of their neck and attach to their neurostimulator, which is also called an internal pulse generator, an IPG, or a battery. It's essentially a battery in a little mini computer. It typically is placed in the chest, but it could be placed in the abdomen. They can have 1 or 2 generators. They can have 1 or 2 leads, depending on their specific situation. Medtronic currently is the only FDA-approved system available here in the United States, but there are several systems that are in the final stages of marketing and approval that will be changing this environment in the next few years. Now, of importance when you're discussing surgery, and particularly DBS with the patients and their families, it becomes very important to let them know that this is not a cure. This typically will get them to their best on. So what it does is, as you can see, the kind of the undulations of their typical on-off fluctuations, it will even that out. So they will still have some fluctuations, but they will be less, and they hopefully aren't going to be climbing up as deep as many times throughout the day. So I make sure that they understand that we will be getting them to their best on more consistently throughout the day. The components of their symptoms that typically are good responders to their therapy, such as tremor, rigidity, bradykinesia, and dystonia, typically are going to get better. If we implant the STN, and sometimes even with the GPI, we're able to reduce their medications, and in that case we can see an improvement in their dyskinesias as well. But the components of their symptoms that don't respond well to their dopaminergic therapy won't respond to medication, and it's very important that they understand that. In particular, if they have gait instability, if they have speech issues and they have cognitive deficits, there is a chance that those can get worse after surgery. So this is that same gentleman. He has now had his deep brain stimulation surgery. He is a year post-surgery now. So you can see his dyskinesias are essentially gone. His face is more animated. He has good motor control. Mm-hmm. He has bigger amplitude, a little bit faster, so less bradykinesia even than he did when he was on, even if you took out the dyskinesias before. Mm-hmm. We've been able to significantly decrease them, yeah. I believe, he's now a couple years after, so he stood up so easy. I believe at this point we were able to get him off all of his dopamine agonists, and he was on just a very small regimen of his carbidopa levodopa. And we have somebody actually in that closet, but you can see how agile he is around that. So, And this is an example of that retropulsion test where you pull on their shoulders. You always want to make sure you have a firm surface behind you, because if they come back, they can come back hard and fast, and you don't want to go down with them. But you can see he still takes several steps backwards. So that's still a positive retropulsion test. Now, I'm not going to go through all the details on the safety issues with the DBS, but there are a couple of big things that I want to hit on. One is once they have had DBS, they cannot have MRIs. They can have a brain MRI with some modifications. I find that becomes confusing for patients, so I usually just tell them no MRIs. If they need one, they need to talk to us, and then we'll let them know what they can have. Truthfully, you just need to know if you have a patient with a deep brain stimulator, if they're going down any type of procedure or evaluation, you need to make sure that you call the manufacturer of that DBS, because there are a fair amount of limitations and modifications that need to happen. And what really happens is people are really good the first couple years, and then once they've had this for a long time, it's just in the background and they don't think about it. So I've had people that have blown out their knees and are coming in excited about the orthopedic surgery and their MRI that's coming up, and they cannot have an orthopedic MRI after this. And we recently, just this summer, had somebody who just on the fly mentioned that she was heading in for radioablation therapy for a back issue, and that's contraindicated. So her doctor, in fact, had said, "Oh, I know those Medtronic devices. I've worked with them before. We'll be fine." And he may have worked with Medtronic devices, but it's different when we're talking about something that's implanted in the brain. And we have significant concerns about anything that's throwing a current through that body, because if we throw that current down that lead, we're destroying brain tissue. And there are cases out there where people have stroked out due to diathermy, which is basically a therapeutic ultrasound that dentists and physical therapists will use, and it's avoidable. So there are also modifications to their electrocautery if they're going in for their colonoscopy or any of these things. So they're not that difficult, but it is important to make sure that whoever's doing those procedures has the manual. And I'll have them call me, but truthfully, if I can get them in contact with, currently it's Medtronic, but there will be other manufacturers coming down soon. You need to get them in contact with that manufacturer so that they can make sure that they're getting the specifics of what they need answered. So in summary, in 2010, the American Academy of Neurology came out with a report that provides a guideline onto how to manage the disease. You want to make sure on an annual basis that you're reviewing your Parkinson's disease diagnosis. And as I discussed, we will often stay on a path of Parkinson's disease, but it sometimes isn't clear until at least 5+ years into the disease that you're not actually dealing with an idiopathic Parkinson's, but rather an atypical, which will take a different pathway down for treatment. You want to evaluate their psychiatric and cognitive issues, their autonomic dysfunction, sleep disturbances. You want to evaluate the rehabilitation therapy options, review safety issues at home, and review their medical and surgical treatment options. And every visit you want to be asking about falls, and you want to review any medication-related motor complications. So as you can see, Parkinson's disease is much more than a movement disorder, and it's imperative for our patients' quality of life that we do take the time out to address these additional issues. So thank you very much for sticking with me all the way to the bitter end here. This is our deep brain stimulation team here at Davis, and they were quite helpful in helping me with many of these slides, so thank you to them as well.